You're listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Stephen R. Feldman, Professor of Dermatology, Pathology, and Social Sciences and Health Policy at Wake Forest School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Welcome to Medscape In Discussion on Psoriasis. I'm your host, Dr. Steve Feldman. For years, we relied on older immunosuppressive drugs like methotrexate and cyclosporin to treat extensive psoriasis. Do oral agents still have a role to play in psoriasis treatment in this era of biologics? I know the perfect person to answer that question, and he's with us today. A clinical professor of dermatology at Yale University School of Medicine, he's the scientific co-director of the Coravitas Psoriasis Registry. He's the treasurer of the International Psoriasis Council and the editor-in-chief of the Journal of Psoriasis and Psoriatic Arthritis. He's also the former chair of dermatology at the University of Connecticut Health Center. He's been instrumental in developing guidelines and standards of care for psoriasis for years now. It's my pleasure to introduce Dr. Bruce Strober. Welcome, Bruce.
Thanks, Steve. Happy to be here.
You know, you and I have been doing this psoriasis thing for a long time. And when we started, patients were really suffering. And we've ridden wave after wave of new drugs. Do you have a favorite story from your experience over these years?
The best story I have is actually how I got into dermatology and how I got interested in psoriasis. I got into dermatology by accident. I was doing a primary care rotation in medical school, and they had no place to put me. So they threw me into a psoriasis clinic at Harlem Hospital in New York City. And by accident, I fell in love with psoriasis that afternoon. When I was a resident, there was a medication that was just coming onto the scene. This was around 2001. And it was not yet approved for anything in dermatology, yet it had an approval for rheumatologic disease. And that name of the medicine was etanercept. And my attending and I started a patient on etanercept, the first patient ever at NYU that received that drug. And they magically cleared up over the course of 2 to 3 months. And I said to myself, that is a lot better than cyclosporin, and I'm going to go down this pathway.
Yeah, wow, that's great. You know, when I first started seeing patients with psoriasis on etanercept, none of them had cleared up. And that's because the only ones I saw were ones that the rheumatologist had treated for psoriatic arthritis, and they didn't send me the ones that cleared up.
Right, exactly. This was one of those situations where we had a psoriasis patient that had not yet been touched. And luckily, I worked with an attending, Dr. Jerry Shupak at NYU, who was always on the cutting edge. And he says, Bruce, let's just try this drug that I hear works for psoriatic arthritis. And the rest is history.
That was sort of the beginning of this revolution where, you know, we're thinking about putting psoriasis patients on these biologic drugs that are extraordinarily safe and effective. But we have these oral agents too, non-biologics. In the 2020 AAD, American Academy of Dermatology National Psoriasis Foundation guidelines, it mentions drugs like methotrexate, acitretin, apremilast, cyclosporin still, and tofacitinib. Talk briefly about these.
Well, I don't think they should be viewed as a monolithic group. I think each drug is a different character in the armamentarium. So, for example, cyclosporin, and by the way, I just wrote a prescription for cyclosporin for a person with psoriasis last week. It still has a place. It's really about a quick clearance of patients who are dramatically in need of improvement now. Because cyclosporin is generic, and it's something you could prescribe today, and the patient gets it tonight. And therefore, they could see improvement within a week or two. There's no prior authorization process like we have with more modern drugs. But cyclosporin has toxicity and therefore always has a sort of a half-life, a deadline at which you should pretty much switch the patient over to something safer. It's the quick fix drug. Rarely do I add it on to another medication in a low dose to get them to another level. Methotrexate, I think, is somewhat the opposite. It's also an old generic drug, probably less effective than cyclosporin, yet it works. It would be a good drug for people who, first of all, have their insurance mandate we use that drug because it's so inexpensive. But if that's not the case, it might be a drug for a person who's poorly insured, who can't afford a more expensive medication, or a person who has Medicare, where a lot of the more modern medicines are not well covered. Methotrexate's a great combination drug with other biologic therapies because methotrexate adds to the psoriasis effectiveness and also brings some psoriatic arthritis efficacy to the table as well.
How about apremilast? I hear some people use it as their first line option.
Apremilast is a modern drug, and its advantages are it doesn't require blood tests like methotrexate and cyclosporin do. There's about a 1 in 3 chance apremilast will be effective, very effective, I should say, for a patient. And that would be the problem. It's not always effective. It's a milder modern drug. The other issue is there's some side effects like nausea, diarrhea, and headache that can pop up in patients on apremilast. Maybe the patient who gets apremilast is your milder, less severely affected patient, or again, a patient you can combine up with a biologic and get better efficacy. And we shouldn't forget apremilast also can help psoriatic arthritis. So people who have cleared skin, but their arthritis is not well managed, you can add apremilast to the equation.
Does acitretin still play a role? It's a retinoid, a vitamin A derivative.
Acitretin, very old medicine, also generic, generally accessible to most patients. The problem with acitretin is, number one, it too isn't very highly effective when used alone as a monotherapy. Secondly, women can't get acitretin, especially women of childbearing, because it is, like any retinoid, a teratogen. And it has this unique aspect of all our retinoids. If you take one dose of acitretin and you have alcohol subsequently while the acitretin is in your body, it's what's called reverse esterified into an older drug that we even use called a tretinate. And the tretinate has a very long half-life. I believe it's about 4 months. And therefore, if you give acitretin and then someone has alcohol, you kind of assume the drug's in their body for about 2 years. So we leave that off the table for women of childbearing. Now, postmenopausal women too, it's a problematic drug because acitretin is associated with mucocutaneous side effects, dry skin, dry lips, but one of the side effects is alopecia. And I think alopecia occurs with a fair frequency in anyone who takes acitretin, such that if you gave it to a woman who's postmenopausal, she's going to lose some amount of her hair. It has been shown that if you combine phototherapy with acitretin, you can lower the dose of both modalities or the frequency of administration of both modalities. That's nice. But you could add acitretin to anything because it's not immunosuppressive, which gives it a unique feature of all our psoriasis therapeutics. But acitretin is unique. It doesn't appear to have an immunosuppressive capacity. So we can add it on to any other drug that is immunosuppressive, and we're not doubling up on the immunosuppression. Finally, acitretin might be a very good drug for palmoplantar disease, meaning hands and feet. And I have seen it work very nicely in those patients. Again, you got to monitor the dosing because the side effects basically are dose related with acitretin.
How about one of the newer medications, the JAK inhibitor, tofacitinib?
Tofacitinib is only approved for psoriatic arthritis. It is not approved for psoriasis. That said, it works pretty well in psoriasis, at least as good as methotrexate at its regular dose of 5 milligrams twice a day. If you gave it 10 milligrams twice a day, you get even better efficacy, but we don't have that as an approved dose. 5 milligrams twice a day, you get decent efficacy. The issue with JAK kinase inhibition is some rare side effects and toxicities which necessitate blood test monitoring. For example, the CBC and the liver must be monitored. But pretty well tolerated medication. I would consider tofacitinib, of all the drugs we just discussed, pretty much as immunosuppressive as any others, as immunosuppressive as cyclosporin, in fact. But it doesn't have the renal toxicity that predictably cyclosporin has. So you can put someone on tofacitinib and more or less make it an indefinite therapy. Where do I use it? I don't commonly prescribe tofacitinib now for people with psoriasis, except if they have palmoplantar disease.
So that was a fabulous overview. And why don't we go through a couple of them in a little more detail? Of the ones we've mentioned, would apremilast be the one that's most commonly used at this point?
Without question. I think apremilast surpassed methotrexate in the last few years in terms of prescription volume. And that's because it's easier than methotrexate. I actually am skeptical it works better. I think methotrexate, if you look at the data, works a little better than apremilast, but it's marginally in its difference. It's just easier as a drug.
So apremilast is a phosphodiesterase 4 inhibitor. I think caffeine is a phosphodiesterase inhibitor. Seems like a very safe thing. You get people past that initial nausea, diarrhea, and they tolerate it great. But who are you choosing to put on apremilast?
It's funny, Steve, because it's definitely not a drug I prescribe as frequently as the biologic therapies. It's probably a 1-to-10 ratio there. It's probably the patient who you can't manage well with topicals, and they're in the sort of the 3 to 8% body surface area of involvement range. And additionally, a patient who is a little reticent about taking an injectable biologic. They would rather move through the oral therapy before they got to an injectable therapy. So that's that combination that brings you to apremilast. And I always feel good about writing apremilast. It never really hurts patients. It's like a low risk opportunity for patients. And in 3 months, if it's not working, you talk with the patient about the next level of therapeutics, which is biologic therapy.
Okay, I get the sense that the second most common one that would be used would be sort of the opposite extreme from apremilast. It would be methotrexate, a drug that you can kill people with if you're not careful with it.
Exactly. And methotrexate, and I prescribe a lot of that too, just needs good patient selection. Obviously, don't want someone who has liver risk, and that would obviously be a drinker or has other reasons to have liver toxicity. People with poor renal function are at risk for bone marrow suppression when getting methotrexate. People on other medications that interact with methotrexate create risk, particularly bone marrow toxicity. And then you have to follow the blood tests. But methotrexate is commonly used because it's so inexpensive and you never get blockade. I shouldn't say never, but pretty much 99% of the time, you don't get blockade from a pharmacy or prescription plan regarding its prescription. And there's a sort of this adherent group of dermatologists out there, probably older dermatologists who are trained more extensively on methotrexate, who like it because it does beat a placebo in clinical trials pretty handily. And I would say, 40 to 45% of patients, if you dose the drug appropriately, get significant improvement. And patients can like that and stay on the drug indefinitely as long as you're monitoring them correctly over time.
Yeah. Are you starting with a test dose of methotrexate and working up, or are you just starting with a full-blown dose of this stuff?
Steve, I never did test dosing. I wasn't trained on it. Dr. Shupak, my mentor, told me never do them. In 20 years, I've never done them, and I've never had a problem. So I start almost everyone on 15 milligrams, unless it's an older person who may have compromised renal function. I might drop them to 10 to 12.5 milligrams. But generally, it's oral, 15 milligrams, 6 pills all at once on the same evening every week. And I have them come back in 4 weeks and repeat their labs and just compare them to the baseline. Thousands of patients later, I've never seen the need for a test dose.
Outstanding. In the old days, liver biopsies were recommended in these patients at intervals to monitor for cirrhosis. Are you doing that anymore?
I haven't done a liver biopsy in 15 years on methotrexate. I think it's really gone the way of the dodo. I mean, the liver biopsy has its own risks, of course, which are not insignificant. It has to be done by a trained professional, and usually it's a liver specialist. The liver biopsy also has a problem in my mind in that it only samples a portion, and a very small portion of the liver, like maybe 1% of it.
Yeah, a lot less.
The pathology may rest outside of the area you biopsy. So I even think the results are unreliable from a liver biopsy. So in that regard, I think liver biopsies are antiquated and not very helpful and carry their own risk. And therefore, we rely on other means by which to measure toxicity to methotrexate. And there are quite a few now being developed, both laboratory and non-invasive imaging studies.
You mentioned drug interactions with methotrexate, and I know a high percentage of patients with psoriasis have joint issues and might be given a non-steroidal, which I guess, at least in theory, could affect renal function. Is that an issue with use of methotrexate?
It really isn't. How do I know this? Once I ran a room derm clinic. It was a clinic at NYU where we saw patients with psoriasis who had a dermatologist present and a rheumatologist present. And working with many rheumatologists over the years, and rheumatologists prescribe probably as many NSAID prescriptions as any other specialty out there, probably, because they deal with pain and joint pain in particular. They always said that is a really erroneous drug interaction. In fact, you can give NSAIDs in moderation to people on methotrexate. The key is NSAIDs in and of themselves have their own toxicities that need to be respected. And therefore, you have to prescribe them judiciously and make sure patients are not abusing them.
Then the big drug interaction for methotrexate would be what? A sulfamethoxazole trimethoprim combination drug?
Yeah, exactly. That particular drug is not uncommonly on board in patients. And therefore, that one in particular has to be looked out for. There's a few others in the textbooks, and I always just use my little handheld device. I have a program that checks interactions and make sure I view them as relevant or not relevant. That's a big one. Make sure they're not on trimethoprim, sulfamethoxazole. If you give them methotrexate, you can really ablate the bone marrow quickly.
Do you think there's much role for methotrexate used in combination with biologics?
Well, I've been doing that for years. And the primary role I found was combining methotrexate with TNF inhibitors, particularly adalimumab and infliximab, because in particular, methotrexate reduces immunogenicity. It actually, in some unknown mechanism, reduces the patient's ability to make anti-drug antibodies. And that's actually been shown very convincingly. And in so doing, it raises the serum levels of both adalimumab and infliximab to higher levels in the patient's body, so you get better efficacy. Now, the question is, do you need to combine methotrexate with the newer biologics? The data aren't really clear on that. Actually, they suggest you don't. So I don't do methotrexate in combination with the current modern IL-23, IL-17 inhibitors. Only if I feel there's residual joint disease that could be benefited by a low dose of methotrexate do I combine methotrexate with a biologic. Or in patients who are getting somewhat of a response, but not a full response, you can add methotrexate to push up their skin response. Now, again, we have so many drugs to choose from. You might ask, well, why don't you switch them to another biologic instead of adding a methotrexate? Well, these would be your end of the line biologics patients who've been through 8 or 9 of them already are kind of running out of options. So then you start combining up therapies with methotrexate.
As physicians are following patients on these drugs, do you think you could do it by teledermatology, especially in a primary care setting?
Teledermatology is a challenge. That said, if a patient is in follow-up clear, well managed on any drug you're using, even methotrexate, you just have to have blood work done, but especially biologic therapy, it's entirely feasible to follow them by a telederm, and I do. So once a week, I'll have a telederm visit with a biologic follow-up, and I think that's great. Why would you want a patient to come in, drive 20 miles, even longer distances, just to say, hello, how you doing? And I'm clear, right? And have a nice 6 months ahead of you. So we do this commonly for patients with well-managed psoriasis. If you're having a flaring patient, I tend to feel more comfortable bringing them in person, examining the skin, getting a sense of the severity, how it's affecting them. And then clearly, when you have a flaring patient, you often have to switch therapies. And that's a discussion, too, that's best done in person. So with teledermatology, stable patients who are doing well are very appropriate.
These oral agents have so many more issues than biologics do. I think it's critical that we educate patients in writing about what to be looking out for and what to expect. And I've relied heavily on National Psoriasis Foundation materials for doing that. Is that something you do as well?
Typically, I don't, Steve, which may be my own failing. And I think it's a good idea to hand literature to patients. So I advocate for that. I think the key here in my practice is we do write down for the patient very critical features of the drug's experience, like dosing, how do you take the drug? But more importantly, we have a phone number that they can call. So if there's any confusion, they reach out to us. And truth be told, there is a lot of confusion that comes on. Even if you're very clear during the visit, patients often don't quite get the instructions correctly or don't listen to your admonitions of certain things you don't want to do while receiving this medicine. But I do believe handouts work, and I think they're smart. Whether patients read them is another question. And if a patient asks for a handout on a medication, we do give that to them.
Excellent. We've covered so much. Are there any other things you want to pass on to listeners before we wrap up?
I think to listeners, the most important thing is you expand your options. Unfortunately, there are about 14 different choices, maybe 15 when we treat psoriasis, and that maybe there's 16 now. Soon there'll be 17 or 18, but you still have a long laundry list. So what I would say to any provider is get to know a lot of these different choices in different classes, because invariably there are patients who don't respond to one class or type of drug that need to have another class brought to bear. And it could be a patient who does respond to a Premolast, but not to one of the biologics. That happens. Patient responds to methotrexate, but not to the biologics. That's crazy, but it happens. And that's why you need to have a full list in your head and be very competent on it so that you can explain and feel confident going into the room. Hey, I have this menu of options for patients, all of which are great. And therefore, I can bring to bear a tailored approach to each and every patient based on their needs, their demographic, their place in life, the severity, what have they been on in the past, et cetera. And I just think it gives you a greater modern approach to psoriasis, which is very treatable these days. It should be one of your easier diagnoses to manage. And in that regard, you're really helping patients in need. It's a common disease, probably one of the more common ones we treat. And so you commonly can help a person or a group of people who come in to your practice on a very regular basis.
We're going to cover biologics in our next episode of this podcast, but I think today we've learned that a Premolast might be a perfectly good first-line option for patients who want an oral agent. Methotrexate still has a big role to play, especially in patients who don't have good insurance or where the insurer requires methotrexate first. Acitretin may be useful for making phototherapy more effective, especially when used in low doses to avoid side effects. And even cyclosporin may still have a role for, emergent treatments right before a wedding, and they got to clear the psoriasis up fast. Bruce, I want to thank you so much for your time today. I'm Dr. Steve Feldman, and this has been Medscape in Discussion on psoriasis.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Stephen Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on psoriasis.